Hello everyone, this is Aman Salim and today we will be discussing examination of foot and particularly according to the AMCL exams. So like any other examination, we will approach the patient with wipe approach, which includes W stands for wash hands before and after, I stands for greet and introduce yourself, P is for plan and permission, and E is for exposure. So I have written this small summary. Hi there. Greeting is done. I am Dr. Saman, which means that you have introduced yourself. I have been asked to examine your feet today. Now you're stating the purpose of your visit. This examination will include looking, feeling, and moving your feet. So you're telling your plan right now. If that's okay with you, so you're seeking their permission, can you please roll up your trousers till the knee joint while I wash my hands? So you have told the ideal exposure. It hardly takes 5 to 7 seconds in saying all of this, and all the vibe approach it is covered in this. Next, we have to comment on the general appearance of the patient, their age, gender, build, if they're oriented in time, place, person or no, if they're sitting or standing, if they are comfortable or they are distressed due to pain, if they're using any protective posture or walking aids. Again, I have shown you a small example, like a middle-aged male with morbid obesity and average height is sitting on chair with distressed expression. No protective posture or walking aids are seen nearby. Again, this is a small intro that gives a good impression to the examiner that you know what you're talking about. You have commented on the general appearance of the patient and you're not just focusing on the foot, but you are taking the patient as a whole. After general appearance, next comes gait. Now it's very important to ask the patient to take a few steps and then turn back. If the patient straightforward refuses that he or she cannot walk, then we will tell the grades of straining. There are 3 grades of strain. Grade 1 is the patient can walk, but it's a painful walk. Grade 2 is that the patient can bear the weight, patient can stand still, but patient cannot walk. Grade 3 is that patient is not even able to bear the weight, and this is a strict indication to have all the x-rays done. So if the patient refuses to walk and says that he absolutely cannot walk, then you have to decide which grade of strain is present. But if the patient walks, then you have to comment if that gait is normal, if the stance and the swing phase, if they are equal or not, or if there is any particular type of gait which is present, like waddling gait or spastic gait or cerebellar gait or Parkinson fascinant gait. Once you have commented on like if what it was a normal gait or no, then you ask the patient to please walk on their heels for you. And at that time, you're checking for L4 and L5. Then you ask the patient to walk on their toes so that you can check for S1. Then you ask the patient to squat and then stand, and then you check for L3 and L4. So once you have checked the gait, you have checked the gross dismobility of the patient. After a vibe approach, general appearance and gait. Next, we move on to inspection. Here I have just written special gaits like spastic gait, scissor gait or diaplegic gait, propulsive gait, high steppage gait. But you must be knowing all of this in your theory. So for now, I'll skip this and let's move forward. So next is inspection of foot, which is normally done in the standing position or sitting position with feet hanging downwards. So now for the foot inspection, you have to do it interiorly, medially, laterally, posteriorly, inferiorly, and in between the toes. So once you started from anteriorly, firstly comes the nails. So you'll comment on the general hygiene of the nails. If there are any ingrown toenails, any sausage-shaped fingers, if there is any clawing and crowding of toes, which is seen in rheumatoid arthritis, if there is any hallux valgus or bunion, if there are any calluses, if there is any varus or valgus deformity of the ankle, if there are any scars, swelling, rash, redness, bruises, deformity, or musculoskeletal wasting. So there is a mnemonic SSRRBDM. This stands for scars, swelling, rash, redness, bruises, deformity, and musculoskeletal wasting. You have to be very sure in your AMC exams that whatever term comes out of your mouth, you know what it stands for and what is its significance. After inspection, we will do it from laterally to check for the pes planus and pes cavus, then posteriorly. And posteriorly, we will comment on the integrity of the Achilles tendon, if there is any swelling, redness, or nodules, if there is any crescent sign. Now, crescent sign is the ecchymosis below the medial malleolus, which is seen in the ruptured Baker cyst. And this lower diagram here, it shows the crescent sign. Then too many toes sign, and this too many toes sign, it confirms pes planus. So basically you stand behind the patient, and normally you should only be able to see 2.5 toes, but if you can see more than 3 toes, it means that the patient is flat-footed. Then comes inferior. On the inferior aspect, you have to see any calluses over the heads of the metatarsals, which are suggestive of subluxation of the metatarsophyryngeal joints. And then we always have to check in between the toes for fungal growth. It can be a critical error in some of the examinations. After inspection of the feet, next comes the palpation. Now, palpation is mostly done in the lying down position. Firstly, we will just check the temperature, then capillary refill to ensure the vascular supply is intact, pulses, dorsalis pedis and posterior tibial, and then we will check for the tenderness. But always remember that before touching the patient, we have to ask if the patient has any pain in any particular area. And if at any point of time patient feels pain or discomfort, they have to tell you so that you can make them comfortable. Now, for the tenderness, you have to check the tenderness in the toes, especially in the interphalangeal joints, which are affected in the seronegative arthropathies. You have to check the metatarsals, because second metatarsal, it will be affected in the stress fractures, and they might have given you a history of physical activity in the stem outside. So that will help you in making the diagnosis. Third and fourth metatarsal, they can be tender in cases of mortis neuroma. And if it is tender, then you have to do its special test, which is Mulder sign and click. Then you have to check the ankle Ottawa rules, which are basically 5 areas. Medial malleolus, 6 centimeter above the medial malleolus, lateral malleolus and 6 centimeter above the lateral malleolus, navicular bone and base of the 5th metatarsal. After checking for the ankle Ottawa rules, then you have to check for the Achilles tendon, if it is tender or not. Now this completes our palpation. Next, we will move on to movements. Always in the locomotor system, you ask the patient to move their joints actively themselves first, then passive and then resisted. So when the patient is moving their joints actively themselves, you are assessing the range of the movement. And then you will do all those movements to assess the tone, and then you will do the resisted movements to assess for the power. Now movements in foot, they are just plantar flexion and dorsiflexion, invariant and evariant. So next are some special tests. Now it depends upon the history. So Windlass test is to check for the plantar fasciitis, if it is suggestive from the history or from the stem given outside, or if it is still one of the differentials that you have to rule out. Then what you can do is you dorsiflex the big toe to stretch the plantar fascia, and then you palpate above the heel, just shown in the above diagram here. So if it is positive, it will be very painful in cases of plantar fasciitis. And these people, they mostly complain of pain on taking the first step in the morning. The maximum pain is felt when they take first step in the morning. Next is Mulder sign and click, which is positive in the Morton's neuroma. And you can see in the lower picture here, you have to squeeze a 3rd and 4th metatarsal in both directions, from laterally as well and from anteroposterior direction as well. And then you will hear a proper click. And this is basically because of entrapment of the digital nerve in between the bones and the fascia. And it is because of wearing ill-fitted shoes, and it gives you a sensation of pebbles in the stone, pebbles in the feet. And there is shooting electric-like pain which is felt in the feet because it is because of the nerve entrapment. Is tailor tilt. Now, if the patient has particularly come with ankle injury, then these ankle integrity tests, these are very important to be done. If you just let the foot hang and you invert, so if you plantar flex the foot and then you invert the foot, so that checks the integrity of the anterior talofibula. If you dorsiflex the foot and then you invert, it is to check the posterior talofibula. If the foot is hanging in the normal position and then you invert, it is to check for the calcaneofibular ligament. Then you can also do the anterior draw test, which is for tibiofibular ligaments. And for this, you place one hand on the lower end of the leg to exert a backward force. And with the other hand, you support the heel and exert a forward force on the foot. So there will be increased mobility if these tibiofibular ligaments, they have been damaged. So these are special tests for the ankle. Next is syndesmosis squeeze, which is to check for the high ankle sprains. And basically you squeeze the leg from both sides, starting from above. It will be painful if there is a fracture associated with interosseous membrane. Next is the heel squeeze test, which is simply you squeeze the heel to check for the calcaneal spur. Thompson test or Simon's test, it is basically positive in cases of Achilles rupture. You ask the patient to lie on their stomach and you let the legs hang downwards from the bed. Then you squeeze the gastrocnemius. If there is plantar flexion, like in the above picture, it is normal, but loss of plantar flexion, it indicates Achilles rupture. Thank you so much for listening. If you have any questions, please comment them down below.